sure. Again, you're not going to need to know septic shock, and you're not going to need to know MOS. Okay, so we're going to mainly be talking about sepsis and the interventions and the nursing assessments to go along with that. As far as some housekeeping stuff, I just want to remind you guys that during class, to be respectful of your classmates, talking throughout class, people can't hear sometimes, and I know sometimes it gets hard to hear me, even with the microphone. So just be mindful. If you have a question, please raise your hand. If there's something that you don't understand, please raise your hand. Otherwise, comments and stuff like that, or things, whatever, besides classwork, please keep it to the break. That way your classmates can kind of, they can hear what's going on, okay? So sepsis in a nutshell. So from that video, what is sepsis? What happens in the body?
Systemic inflammatory.
Systemic inflammatory response. That's actually something that you'll see in your book. It's called SIRS. And what happens then? What happens with SIRS?
Hypercoagulability, hypoperfusion, edema, all that fun stuff.
So with SIRS, there's some criteria that SIRS has, and we'll go over that criteria. But sepsis is actually SIRS that comes from a known or suspected infection. So that's the big thing that happens, and that's why we talk about it in the infection concept, is that sepsis occurs when infection is present. There is a continuum, so you can have severe sepsis, and that's associated with some type of organ failure. Hypoperfusion occurs, hypotension occurs, and then, so what do we give them? What does she talk about? Fluids, right? So we give them fluids to help this hypotension, to help this hypoperfusion, because they've got all of this leakage and vasodilation and leaky capillaries, and the fluid isn't where it's supposed to be. And so if that fluid doesn't resuscitate, and the patient's blood pressure isn't holding where it should be, then they can go into septic shock. And septic shock is when there's a persistently low mean arterial blood pressure as a result of this overwhelming infection that occurs, and it doesn't respond to adequate fluid resuscitation. So there's some physiological evidence of cardiac instability that doesn't respond to fluid resuscitation. And normally that means that the systolic blood pressures are typically less than 90. Why do you think we talk about sepsis? Why is it important?
Because it can kill people.
Right, we want to prevent it. Why do we want to prevent it? Right, it can kill you. Exactly, right? Bad things can happen. So, where do you think last week we talked about pneumonia. And it was what on the leading causes of death? Do you guys remember where it stood? 8, right? So where do you think sepsis is? Somebody said it. I heard it. 11. Jessica, very good. It's 11 on the leading causes of death. So again, within the top 15 killers, and it's a leading cause of death in non-coronary and ICUs. So think about that. You have ICU patients that are really super closely monitored, right? 1-to-1s, 1-to-2s, and they're dying from sepsis. That's why we talk about it. Who do you think is at risk for sepsis? Elderly, why? Say it really loud and say it proud.
Their immune system isn't as strong as it should be.
Good. So said their immune system isn't as strong. Why else? Question.
A lot of times they have other conditions that can also increase immune system.
Okay, so Gretchen said that they have other comorbidities that can affect their immune system. It also can affect other systems.
Yeah, like blood pressure and
Right. So in elderly, they don't have that elasticity in the myocardium. They don't have elasticity in their walls. Their valves are more rigid. They have decreased stroke volume, which affects cardiac output. So when you hear those things, what do you start thinking about? When you hear decreased stroke volume, Decreased cardiac output. What does that affect? So perfusion. And they don't have the compensatory mechanisms like younger individuals have when those things start getting affected to have a compensatory action to kind of help, right? So when you think of somebody that could potentially be having low blood pressure, you might see their heart rate start to tick up, right, to compensate for that low blood pressure. Sometimes elderly people have that, and sometimes they don't. Or if they have a lower heart rate, they might, or a higher heart rate, they might not have the compensatory mechanisms to compensate for that. Who else is at risk? Infants. Why infants?
If you're under 6 or 7, you don't have a fully developed immune system.
Say it, I couldn't hear you, I'm sorry.
If you're under 6 or 7, you don't have a fully developed immune system.
Okay, so infants have definitely, they have immature immune systems. What else?
If you have like a PICC line or something.
Good. So if you have something like invasive, right? We've got that break in the skin. We've got that allows infection to potentially come in. Good. And who else would be that? Like if you're thinking a PICC line and that break in the skin, who else? Patients going under chemotherapy because they're what? Immunocompromised. Good. Who else fits into that category of immunocompromised? Not just chemo patients, yeah. Okay, who else? Lily?
Diabetics.
Okay, who else? Somebody?
Diabetics.
Diabetics. Who else? Abby? Good. People that have had surgery. What about somebody who had their spleen removed? Yeah? What about somebody that's on long-term corticosteroids? What about somebody that has sickle cell? Okay? How do you think an infant would look? And how would it differ than an adult if they were potentially going down the septic road? They could. Maybe.
May not be eating.
Yeah, poor feeding. Good.
Would it be quicker just because they're smaller?
It could be. It could happen faster. Okay.
Abdominal distension and hepatomegaly.
Good. Abdominal distension, hepatomegaly. Do you think these kids would be like chilling, calm? No, they're probably going to be crying. They're going to be irritable. Little lethargic, yeah. Think they'd be vomiting maybe? Okay. There are two or three more categories of people at risk.
Transplantations.
Transplantation. Yeah, I could see that if they were on some immunosuppressive drugs. Terry. Patients who are pregnant. It might, yeah, maybe. What about IBD drug users? Intravenous drug users? Okay. What about people that already have comorbidities? Are they more at risk than a person without? Okay. How about people who have poor nutritional status? Right? Okay. Bless you. How do we prevent sepsis? What are some things that we can do? Immunizations, very good. What one in particular? There's one immunization. I heard flu, I heard pneumonia. Okay, pneumonia is the big one. Pneumonia is a major cause of sepsis, so we definitely want to encourage people to get that pneumonia vaccine. What else can people do? What else can we do? Yeah. Good. Wash your hands, right? Wash your hands. What else?
You can educate them for early signs of sepsis.
Very good. Educate them on early signs and symptoms. What else? Aaron.
Good nutrition.
Good nutrition. Good. What else? Tommy.
Treat infections early and aggressively in susceptible populations.
So early intervention is always good. Shelby.
When your parents are like catheters or midlines or whatever, you make sure
Good. And how do we change a dressing in a central line? Do we use Sterile technique, aseptic technique, very important. What else can we do when these people are in the hospital?
Just monitor vitals and administer antibiotics as ordered.
Very good. You monitor these people closely, okay? All right. So this is a definition that I got out of an article, okay? It says sepsis is defined as at least two SIRS criteria, that's systemic inflammatory response syndrome, caused by a known or suspected infection. Okay? So here are some of the SIRS criteria. A core body temperature greater than 101 degrees Fahrenheit or less than 96.8. Super important because everybody's like, oh, fever, right? We're looking for fever. But you also want to see if the temperature is dropping. Their heart rate is greater than 90. Their respiratory rate is greater than 22, or their PaCO2 is less than 32. And then these white blood cells, look at that too. Like everybody knows when white blood cell counts are high, not good. But also when they're low. Or those immature cells also. So if white blood cells are greater than 12,000 or less than 4,000, or they have a 10% or greater of immature cells. So, as I was kind of going through stuff, I'm looking through, an evidence-based practice in 2018, this is not something, this is FYI, guys, okay? So, FYI, 2018, there was an update. And the update is that they're stating sepsis is this like body's overwhelming and life-threatening response to any infection. It'll lead to tissue damage, right? We know this, organ failure, and potentially death. There's some newer assessment tools that are out there. One is called the Q-SOFA, and the other one is called the SOFA. And these are just tools for sepsis, so you may see them included in like your hospital protocols or your sepsis bundles. So I'm just giving you guys a heads up. If you see something that says Q-SOFA, or if you see something that says SOFA, the Q-SOFAs I believe are being used more on like the med-surg floors, and the SOFA is being used on higher acuity floors. So just a heads up, again, nothing that you're going to be tested on, but just evidence-based practice. There's some newer 2018 guideline updates, okay? What are your patients going to look like? Like we have this criteria, right, which is awesome. We take vital signs, we can look at labs, but you don't always have that information like right away when that patient comes into the emergency room. Or you walk in for the first time on a Monday morning looking at your patient, right? You might not have all that information. So what's your patient gonna look like? Lethargic, okay. Karen? Fatigued, all right. Tachypnic, good. Shelby? Maybe warm and flushed. Okay.
Bleeding and bruising from the bronchocytopenia.
They may have bleeding and bruising. Anybody else? Jessica?
Would they be diaphoretic?
They could be diaphoretic or clammy, right? They might not actually be visibly like sweating and dripping, but they could just be that like kind of clammy to the touch. Amy?
Confused.
Confused. Good.
It could be comatose.
Comatose, okay.
Do they look pale?
They may look pale. Might maybe have some nausea, vomiting. They might not feel well. Okay. Right, but that's not what they look like, right? Like that's a good one, and that's absolutely correct. They may have a lower blood pressure, but that's more of an assessment that we do. Just this is like, what's your patient gonna look like? Okay. What could they maybe complain of? Pain. Good. What else? Yeah. Maybe anxious. Okay. Do you think what happens when people have a fever sometimes? They get flushed, you're right, they get diaphoretic. What else can happen? Which can actually make the fever worse. They're cold, they shiver, right? They get the shivers. right, so we talked about pain. Sometimes that pain can be extreme. Their heart, right? They can be tachycardic. Diaphoretic or clammy. Kind of tachypnic or short of breath. They can be confused or disoriented. They can have a fever. Or they can be shivering and cold. Okay, so we are going to, the rest of the class, we're going to talk about Mr. Sherman Red Yoder. So we're going to listen to a little bit of Mr. Yoder's history here. He's just going to talk to us. Nothing that you would get in a report, just kind of like what he might tell you on a health history or a patient interview. All right, so I want you guys to listen to this. And I want you guys to just write down some like key things that you might hear, because I'm gonna talk to you and ask you a couple of questions afterwards, okay? Let me know if y'all can't hear it. I feel like some things are really super loud and other things aren't.
I understand you want to hear my stories. Well, I'm not much for talking, but I can give you the highlights. There's a lot that's happened over my 80 years. From the top, my name is Sherman Yoder, but I answer to Red. No one around here even remembers my real name. I was born in this house in the downstairs bedroom. Mom had already delivered 6 kids, and there was no way I was waiting for Dad to finish feeding the hogs and get Mom to town before I come out. Oh, Mom used to love to tell that story. Dad bought this farmhouse and the first 100 acres right before he went off to World War I. Folks saw good times and bad in this old place, and so have I. All my brothers and sisters left the land as soon as they could. I was the only one of the lot to care about this place and want to carry on what Dad started. I really haven't gone far from this spot in my entire life. The one time I got it in my head to try something different, I wound up in Korea with an army uniform on. I was glad to get back to this place after that stint, and here I've been ever since. Married the neighbor girl Bessie when I got back. Her dad wasn't so sure it would work out, since she was 8 years younger than me, and she intended to go off to the state college. We sure did prove him wrong. We celebrated our 50th anniversary the week before Bessie died. The ladies at the church had the hall all decorated up, and we brought Bessie home from the hospital for the afternoon. She was bound and determined to live for that day. No way did she want her friends to go to that much work for her not to show up. I couldn't believe it when the ladies had to prepare for the reception after we buried Bessie in that same hall 1 week later. We had such a good life together. That was 10 years ago. I don't do much of the farm work anymore. Our son John takes care of the crops and the few animals we have. I still go out to the hen house every morning to collect the eggs. I'm a little stiff in the morning, but I get loosened up enough to walk out to gather some fresh eggs to go with my bacon for breakfast. I get into town at least once a week. On Monday morning, me and my buddies meet at the VFW for our coffee and donut break. I get caught up on all the town gossip, and we laugh and bellyache about what's going on in the world. 3 weeks ago, I celebrated my 80th birthday. My daughter-in-law Judy organized a big to-do at the church after the Sunday service with cake and ice cream and all the fixings from the party. I had a big piece of cake, but I skipped ice cream. Doc Baker was there, and I knew he would scold me about too much sugar. You see, 6 months ago, he told me I had diabetes. Then I started taking a pill for it. But a few weeks ago, he put me on insulin. I figured I should be able to eat what I want, couldn't see me. Wouldn't you know, his office nurse, Helen, came in the kitchen with a load of dishes just as I was putting the last bite in my mouth. She just winked at me and smiled. After the party, I went out to the mall with John and the grandkids. I'm not one for shopping much, but I needed a new ink cartridge for my printer, and the computer store is the one place I like to look around in. Too bad we parked clear on the other end of the mall, so the kids could go by their favorite stores. Grandpa bought them a little something. John got real mad at me when I asked if I could sit and rest for a while. So I just kept walking. I guess my new shoes were a little tight. I didn't feel anything. But when I got home, there was some blood on my sock, and then I saw a sore on my big toe. Must not be too bad since it's not hurting, except when I try to put my shoes on. I showed the sore to John and Judy the other day, and Judy said she would call the doctor to see what she should put on it. John gets so irritated when I need extra help. I hope I can just continue to soak my foot in hot water to clean it out. Judy was a nursing assistant out at the old folks' home for many years. I'm hoping she will be able to help me with this. I like the idea of the home nurses coming out here as long as my VA benefits pay for it. That way, they can see that I'm doing just fine living here on my own. I was searching on the internet for the best way to treat this sore. There are so many sites that talk about foot sores if you're a diabetic. Some of those pictures are pretty scary. I can't sleep at night thinking about what could happen if this doesn't heal. Of course, I haven't slept through the night for years. Even the couple of beers I have at night when I'm on the computer don't seem to be helping anymore. Judy sometimes gives the kids Benadryl to help them sleep. So I've been taking a couple when I go to bed, and they seem to help me sleep a little better. As a matter of fact, I need to wrap this up now. I promised Jack, my grandson in college, that I'd Skype him in a few minutes. He just started the agronomy program at the university. I love to hear about what he's learning and give him encouragement to come back to the farm.
All right. So what'd you guys think of Red?
Sounds like a swell fella.
Sounds like a swell fella. All right. So, what do you think are Red's strengths? Like, what does he have going good for him? He's active.
Good interpersonal connections with family and friends.
Good. He has a close group of friends, right? He meets every week with his VFW friends. His family, son and daughter-in-law, live pretty close.
Yeah, seems pretty mentally competent.
Yeah, cognitively, he's really competent, right? Yeah.
He's still excited about learning.
Right. He wants to get on the computer, right? He's 80 years old. He's getting on the computer. He likes to go to the computer store. He's Skyping his grandson. What else? Anything else? What about his ties at church? Definitely a strength, right? So he's got his family close by, he's got buddies at the VFW, and it sounds like he's got pretty close ties at church. So that's a whole lot of support that he's got, which is really super important, okay? What concerns you about Red? Jessica?
Diabetes doesn't seem to be controlled.
Okay. So he's got some out of control diabetes.
Yeah, his son John is really
Okay, his son John gets irritated, so I think that definitely look into that further.
He likes to research remedies that he may not be able to trust that make his condition worse.
Okay, so he's going on the internet and he's like, there's all these things out there that I could do, right? Like, so Dr. Google isn't always the best source, all right? Tommy?
He eats eggs and bacon every morning and then a few beers every night.
Right, so his diet, right? His diet's definitely concerning.
Sounds right.
With Benadryl.
Okay. And the Benadryl at night, right? And what else is he having with that Benadryl? couple of beers, right? He's having a couple of beers, and then he's having some Benadryl. Definitely concerning. What else? He lives alone, okay? Even though he seems pretty physically and cognitively intact, he is 80 years old and he lives alone on the farm. Although it sounds like John comes in pretty regularly to the farm to do work. What else is concerning to you? Yeah?
He has a pressure ulcer on his foot.
Good. He has a pressure ulcer in his foot that he didn't even feel it come on. All right? He had no idea. When he took his shoe off, he just had blood on his foot. Amy?
He's soaking that foot in hot water every night.
Okay, which for a diabetic, maybe it's too hot. Okay, and he might not know. Anything else that concerns you?
He said he's been able to sleep for years, and
Okay.
He served in Korea, so there could be like a psychological tie-in, or maybe he's just not sleeping well.
Okay, so Tommy said he hasn't been able to sleep in years. He served in the war. He's wondering maybe there's some psychological component there. Okay, he's activity intolerant. He parked real far away, right from his favorite computer store. So even though he's physically active, how far away is the computer store? Is it a half a mile away? I mean, some of those malls can get right big, right? Or is it 500 feet from where he would normally park? Anything else? Is he working?
He's 80.
A little bit.
He's 80, right? So what would you be concerned about? Finances, right? He's now a diabetic.
He has the VA benefits.
Yeah.
Right, so he has VA benefits, but do VA benefits cover all of your medications? Maybe, I don't know, right? So you have to think about he's a newly diagnosed diabetic. He's going to need strips. He's going to need a monitor now. He's been put on insulin, all of those things. So think about his finances. Okay, can he afford his medication, right? All right, I think we kind of talked about some of these causes of your concerns. We talked about sleep, right? Talked about family dynamics for Red. Talked about the VA benefits. Is it going to cover his home care?
What's he eating? Other than bacon and
Right? He said donuts. He has donuts on Monday. He has bacon and eggs. But what else, right? His cake on his birthday. His nutritional status. He didn't touch the ice cream, so he knew not to do that. What other information do you guys need? What are some next steps? Like, what would be some good questions that you'd be ready to ask Red after listening to this? Is he, okay, so is he being compliant? Yep, with his meds.
I was gonna say, does he take any other medication?
Does he take any other medication? All we know at this point is that he has diabetes. Maybe he's got some other comorbidities going on. Okay, Aaron? Does he have any allergies? Good.
His activity level throughout the day.
Okay, his activity level throughout the day. Good, Kyle.
How often is he checking his blood glucose levels? Because he didn't mention that.
Very good. Blood glucose monitoring. Are you doing it once a day? Are you just doing it fasting? Is he just doing it when he wakes up in the morning? Or is he doing it after he eats, right? His postprandials also, because that can make a huge difference in those A1Cs. You might have awesome fastings, but then after you eat, you could skyrocket to 350 or 400, and if you're not monitoring it, have no idea. Ellen, did you have something?
no.
Okay. What else?
How many beers is a couple of beers, and how many Benadryl is taken?
Right. He said I take a couple Benadryl and I have a few beers, right? Or maybe it was vice versa. But a few in somebody's mind could be 3. A few in somebody's mind could be 6. Maybe he's taken 2 or 3 Benadryl, right? So how much is he actually taking? Yeah, Heidi.
He was in the Army in Korea, so did he smoke?
Did he smoke? Very
A lot of
good.
people.
Good. So Heidi said he was in the Army in Korea. So did he smoke? Because a lot of people in that era smoked, right? They didn't know the health consequences of it. So that's a great question. Anything else? What about his actual functional status? Yeah.
I was just gonna say, how is he coping with the passing of his wife? Like, even though it's been 10 years, maybe that's why he's having problems sleeping if he's having issues with depression.
Good. So he was married for 50 years. He spent 50 years with one person. And it has been 10 years, but he lives on this big farm by himself. Like, how is he coping with all of that?
Talked about being stiff in the morning. You might want to look at like arthritis. Or...
Okay, so he talked about being stiff in the morning. What would you worry about somebody that's 80 years old, who's having a couple of beers every night, who is having a Benadryl and tells you that he's stiff in the morning? Falling, right? So again, his functional status, has he fallen? If he has, how many times has he fallen? We talked about the difficulty sleeping. Anything else?
Eyesight, does he go to a podiatrist? Does he go to the doctor regularly? What's his blood pressure like?
Good. Amy said eyesight. Does he go to the podiatrist? All those things that come along with being a diabetic. Very good, guys. All right, so what is Red experiencing now? What's he experiencing with his toe? Okay. So maybe some diabetic neuropathy, right? He walks that long, long distance to that computer store, took off his shoe, he's got blood. So what do you think is going to potentially complicate this sore that he has on his toe? Decreased perfusion, probably caused by what? Diabetes. And again, we don't know what other comorbidities he has, right? Like if he has some high blood pressure issues, if he's got some peripheral vascular disease, we don't know any of that. Yeah?
They could be, get infected
Could get infected. Why?
because he's not treating properly or cleaning it.
Okay, so we've got a couple of things, right? So we don't know what he's cleaning it with, right? He said he kind of went on, he's soaking it in hot water. His daughter did call the doctor, but they don't say what he was given. They don't say what the treatment is. And then he's got the diabetes that could potentially and probably would impede the healing process again because of perfusion. Right, so good. So Louis mentioned he had the ulcer. He doesn't know for how long because he couldn't feel it. It's been rubbing against that dirty surface and it's been open and exposed. What do we know about skin that is open? Skin that breaks in lets what?
Infection.
Infection in, right? A potential for infection in. And again, with this patient, he's got a lot of other kind of ticks against him for an infection kind of going and getting a little bit worse. Okay? So we're going to take a 10-minute break, like based on report what your concerns would be. So which vital signs would be your highest priority for this client?
Heart rate.
Okay, so I've heard SpO2. Why SpO2? Okay, perfusion. I've heard heart rate. Why heart rate?
Because if it goes over 90, then part of that criteria.
Okay, so Gretchen said if it goes over 90, then it's part of the criteria for sepsis.
Temperature.
Temperature. Okay, why temperature? Fighting the infection. Now, what if the temperature was like 96.6? Would that be a high alert to y'all?
Yes.
Okay. So it was what? What was his temperature? 102. Good. Okay. So how would you prioritize your care based on the information that you received in report, and why? How would you prioritize your care for that patient? Tommy?
You have to prioritize it based on your like initial assessment, right? So after the vitals, you have to look at it and see like what do I need to do first.
Okay, but just on a report. Just like if y'all are at clinical and you get a report from that nurse and this is all that you have, right? This is all that you've got. What would be a priority? Your assessment? Good. Looking at his toe. I'd want to see that. I'd want to see that foot that, and I'd also want to see that catheter that got put in. They said there's not much urine. Like, what's much urine, right? Like, is that 100 mLs? Is it 20 mLs? Is it 45? Is it 200? I'd want to see that. I think we already talked about we want to know when it was inserted. Okay, how far away is he from the hospital? Is he a 5-minute drive? Because, you know, if he put out 20 in 5 minutes, if he put out 100 in 5 minutes, but if he put out 20 in an hour, a little bit of a difference, right? What else from shift report? Shelby?
I was just gonna say, like, neural assessments have been really important because it's like constantly just decreasing and like they weren't acknowledging it.
Right.
See that in for the assessment, but I was just
Okay. So from the report, though, we didn't hear anything about his neurologic status, right? So that would be something that I would want to know, that I would want to assess. We already kind of talked about this. Which vital signs would be the highest priority for this client? So which system-specific assessments or reassessments would be the priority for this client and why? So you don't have to say a specific assessment, just say which systems you guys would be focused on. Gretchen?
Well, I mean, not system, but vital signs, just because they change so quickly.
Okay. So maybe monitoring his vital signs a little closer. Respiratory and cardiac. Why?
Respiratory because his pulse ox was low, that and his change in level of consciousness, and also perfusion.
Okay.
Cardiac blood pressure was going down, his heart rate was going up.
So Sarah said,
His foot was full.
looking at respiratory and cardiac, his SpO2 when he arrived on room air was 95%. His heart rate was 86, and then it started to kind of bump up for his heart rate and go down for his SpO2.
Neuro, because he doesn't really know where he's at. He's saying bananas and talking about the dog.
Good.
It needs to keep being reoriented to where he is.
Good. So neurologically, he's a little off, right? You could even get that before he started saying things like bananas and where's the dog and all of that kind of stuff. He had a really hard time. He was kind of slow to respond for even things like the date and the time of year. He knew who he was, right? But he was forgetful. He kept saying, where are we? How did I get here? What's this? Am I in the doctor's office? No, you're in the hospital. Shelby. Yeah. That'd be really important to me. Like, I want to, what's going on down there, right? Like, what does this look like? When you saw the foot, what did you think? What did it look like?
Red.
Looked red, right? What about the capillary refill? Sluggish. You guys remember from the rat video if it's sluggish and slow, right? Okay, sepsis is on the horizon. Anything else? Really? It was cold. It was cool to the touch, but tells you what? Perfusion isn't all that great, right? Okay. Anything else that you guys can look at? Okay, so what interventions do you guys anticipate? How about this? What interventions did they do, and which ones did they do but do incorrectly? Shelby? I'm sorry? Yeah, yeah. They hung the antibiotics before the cultures. Very, very important. You want to get those cultures before you hang an antibiotic. Okay?
Would it make a difference that he was already on an oral antibiotic?
So since he was already on it and he was getting worse, my thought is that they're not working, right? So remember we talked about last time that sometimes people are on this kind of broad spectrum antibiotic. The goal would have been to get a culture of that before any antibiotic would have been started. But if he's on this antibiotic and he's getting worse and getting worse, my thought would be is that that antibiotic, the bacteria is not susceptible to that antibiotic. So yes, you would still want to get those cultures before starting like an IV, which is like, okay, like you're on PO, and he's got poor perfusion. What has to get there? It's got to get there, right? Like that antibiotic has got to actually get into that spot. So absorption, all these other things. What else? What else did you guys notice? Yeah? They took the urine culture from the drainage bag. Urine collection is one of your guys' skills. Okay, so how, if it was an indwelling pathogen, how would you take that urine? Okay, so Katie said from that little hub that's on there, which is right. What would your first step be? Very good. Did she have gloves on? Did she have gloves on at all? No. So that goes back to making sure that you're what? Washing your hands, making sure that you're having proper hand hygiene and wearing gloves. Because she did not do that, and then what did she do to that foot? Touch that foot, yeah.
I'm watching them take a urine call from a urine session if it's branded bag.
So you really should be taking it from the hub. That's the correct way to do it. Okay? So what do you do first? Clean. Okay, but you have to do something first to the actual Foley catheter. You have to clamp it, right? Because you want new urine. Like you want fresh, new urine, okay? And the urine can't be obtained from the drainage bag. Then what do? So you clamp it for like 10 to 15 minutes. You clean the port, okay, with a disinfectant wipe for at least 15 seconds, and you let that dry. You can attach a lower lock syringe to that. Every catheter is a little bit different, okay? This is just generically. Not every catheter has an actual lower lock on it. You're going to withdraw 3 mLs for culture and about 20 mLs for an actual urinalysis.
Can you repeat that?
Sure. You're going to clean the port for 15 seconds with a disinfectant swab, allow it to dry. You're going to attach your lower lock syringe to the catheter sampling port. You're going to draw roughly 3. Again, remember how in the central line I gave you all different tubes, and some of them were like 4, some of them were 3, some of them were 5, right? You want to look on that tube and see how much you need for that culture. So roughly 3. Most of the time they're gray top tubes. Yeah, gray top tubes. So you're going to get roughly 3 for the culture, and then 20 for a routine urinalysis. You're going to transfer the urine from the syringe into a clean urine container, or sterile urine container. Then what are you going to do? What is so super important that you remember to do? Unclamp that catheter and allow the urine to drain into the drainage bag. Okay? So yeah, she got this from that bag, right? We don't know how long it's been there. What else? Yeah. Sure.
Is the urine collection specific to sepsis, or is that just a still need for infection?
That-
I only ask because the local doesn't have infection.
So urine collection, you might do that if you think somebody has a UTI, right? Or if they suspect maybe a caudy or something like that. A lot of times, like where I was, we had something that was called a fever pack. And so there would be all these different things that was included in that bundle, urine culture and sample, like a CBC, blood cultures, all of that was included.
I guess my question is, like, if the patient is septic, are there going to be any features that we're looking for in the urine culture, or is it just like a precautionary?
So you're looking for a source at that point. You're getting the urine culture because you're looking for a source of infection, right? So at this point, like we probably know that the infection is coming from the toe, but the urine culture would be again looking for like that was a source of infection. Okay. And if he's confused with things, you don't know. He could have a urinary tract infection on top of what's going on in his foot. Okay. What else did they do? Okay, EKG, right? We're just checking his heart, making sure everything's going with that. He's confused. He's a little tachycardic. Will, did you have your hand up? No.
I have a question.
Sure.
What if you have a patient using sepsis but they're on fluid restrictions?
If they're on fluid restrictions and they're septic. So they're on fluid restrictions like for heart failure. So sepsis can actually cause heart failure. I think that would be like a patient-specific thing. I mean, the idea is that they're fluid deficient because the fluid is coming from the intravascular space to the extravascular space. So you need to fluid resuscitate them so that they have that volume status back so that they are perfusing. Okay. Anything else? What are some other things that the nurses did? Yeah.
They tried to fill in the gaps with the daughter, ask her some questions.
Yeah, so they tried to, all those questions where you guys were like, what about this? What about this? They tried to fill that in, like how long has he been taking the antibiotic? How long has this been going on? Is the confusion new? Is this something, maybe that's his baseline. What if this patient had dementia? Okay, maybe that's his baseline. What else? What are some interventions that they did? Yeah?
Like pain assessment, kind of.
Okay, they asked him if it hurt, right? And he said when he walked on it. They didn't go down the old cart route though, right? They didn't ask all of the specifics, which can be super, super important. If it's radiating, if it's sharp. He said it hurt when he walked on it, right? But does that mean that it doesn't hurt when it's sitting there and doing nothing? What's another thing that the nurses did? Yeah.
They did an EKG and then gave him oxygen when the sats
Right.
were going down.
So they gave him O2, right, when his stats started dropping. The order was for below 94, and he was at 93. So they gave him some O2. What did Professor Keller, what was she taking? Right. She was doing labs, right? So what labs would you anticipate for somebody? Like what would maybe you look at in like a sepsis bundle or a sepsis protocol? CBC, right? What are we looking at there? White blood cells, right? And, right? So any of the immature cells, right? Looking at the H&H. We want to see if they're hemoconcentrated. We're looking for signs of like a decrease in platelets. What else? The ABGs. Yes, I'm sorry if you said that, I didn't hear you. Yep, so ABGs. What are we looking for there? Good. Acidosis, okay? What's another one that you would anticipate?
The kidney function.
Kidney function. So yeah, like an electrolyte panel or a BMP, looking at your BUN, your creatinine. When they got that urine sample, they'll probably be looking at like some urine spectrogravity. They might do like an osmol, okay, to see what the osmolarity is of both urine and the blood. What else could they be looking at? What were those big tubes?
Blood cultures.
Good, good. How many of those do you normally take? 2 sets. Okay, so blood cultures are normally done in 2 sets from 2 separate spots. Okay, just to verify and confirm. And what would that tell us? What do the blood cultures tell us? Good, so that tells us that the bacteria has gone into the bloodstream, right? So septicemia. What's another common blood test that they do for sepsis? Lactate, very good. What are we looking at when you do a lactate level? Somebody said it, I heard it. Hypoxia, very good. So we're looking to see if the organs are getting enough O2 when we're looking at lactate. What else might we look at? We talked about BUN. What other things in that BMP would we be looking at potentially? Somebody said liver function? Okay. But that would be, so BMPs, remember, are minus the liver. When you add a CMP, you add that liver stuff in, okay? All right. Ooh. Let's see. What nursing intervention do you think has the highest priority? Fluids. Very good. Fluids. That fluid resuscitation is so super important. So that would be your highest priority. And then what? Okay, your airway, right? I would agree. But just in like the first, before Red started having that kind of decline, you have those orders. What are you going to do first?
The blood cultures.
Abby said fluids and then blood cultures. Why?
Because we want to get those done quickly so they can do processing.
Good, because do they come back like this?
72 hours.
No, like it takes, sometimes they'll result at 24, and then they'll result again at 72. So it might say at 24 hours, no growth, or something like that, but then they result again at 72, most of the time, okay? So you want to get those started, and then what? Your antibiotics. Good. All right, so what assessment findings are most concerning to you? Fever. Okay. Change in mental status. Decrease in blood pressure. Okay. I'm sorry, I couldn't hear you. Good. Decrease in blood pressure, up in heart rate, all concerning. What else? The decrease in the SpO2, right? This is like kind of forming this like perfect septic storm, right? When you look at all those SIRS criteria. Good. His respiration rate started out at 28. What do you think about that in general? High, right? So be tachypnea. Yep. Excuse me. His urine output, very good. What does that tell you? What does that decrease in urine output tell you? Right, so it's either a perfusion problem, right? So maybe the kidneys just aren't getting enough blood, or there's a kidney issue and they're getting plenty of blood, but they're not filtering, they're not creating and processing that blood and making urine. And what did the daughter say up until that point about when they questioned him about like eating and drinking? So he didn't really eat that day, right? But that prior to that, he was eating. But what's normal for him? Like, what do we know about Red? Like, he's drinking a couple beers, which are diuretics. He's having coffee. He's not really having a great diet. I don't think that he's probably whacking back his like 2 to 3 liters of water every day. Okay. All right, guys. So, before we go over objectives, do you guys have any questions? What were some of the things that you guys noticed besides like the urine and besides not wearing gloves when they were touching that wound? What other things? And somebody said the vancomycin before the cultures. That was a good catch. What else? Yeah. Okay. So Anthony said they did hand hygiene, but then they shook hands and then went to the foot. Okay. What? Yeah.
Neither of them were positive. They didn't even ask us diabetes. She didn't ask our allergies until after she had already started.
Good. So that like progression, right? Like, let's ask some questions first. And sometimes, in some situations, you're asking those questions while you're maybe taking some vitals, or the tech might be taking vitals and you're asking questions, but there's still pertinent questions. Like, we still, besides what Red told us in that dialogue that he had, or monologue that he had, what about the diabetes, right? Right, or any other medications. Good. Kim, did you have something? Okay. Anything else? What about when she put that IV in? Did she have gloves on? Nope. No gloves when she put in the IV. What about when she was hanging the vancomycin? Katie said she didn't back prime it. And what else? Stuff went everywhere, right? She was like, oh, I took a shower. Okay, so stuff went everywhere. Which, what did she lose? Medication. Okay? Yeah.
I had a question. So we said that it was like incorrect that she like hung the antibiotics before the cultures.
Mm-hmm.
Is it wrong for her to do that because like the cultures haven't been drawn yet?
Yeah.
So like right after the cultures would be drawn, then she would be able to do like the drawn.
Yep. Yep. So she was saying, why was it wrong that she hung the antibiotic first and didn't do the cultures? So you always want to do your cultures first and then give them the antibiotics. so that the antibiotic isn't going to affect the culture. Okay? All right, anything else? No? What was one thing that they didn't address as far as the daughter? Psychosocial concerns, right? That daughter was scared.
We'll take good care of them.
Right? And they said, we'll take good care of them, you know, all of those things, right? But she said, I'm real scared, right? And they did a pretty good job addressing that. But just be mindful that when people come into the emergency room or into the ICU, maybe they're getting upgraded from a med-surg floor to an ICU. People, you know, lay people don't have an understanding sometimes of what is going on. You know, why is my loved one like this? Like, what's happening? Are they going to die? Right? Like, all of these questions. So just be mindful of that to kind of take a second, you know, or if you can't, ask for help. Maybe your charge nurse needs to come in and say, hey, look, I've got a family member that's really scared. Okay, I've got a family member that really needs some guidance here. Can you come in? Do you mind coming in and helping them out? Okay. So, objectives. These are just going to be kind of specific to what we did today. Again, if you have 1 minute paper things, please pass them all to like this end, and I will come and I'll collect them. Okay, help me help you, and I will post them hopefully by the end of the day today. If not, definitely by the end of the day tomorrow. Okay. So objectives. We talked about the pathophysiology of sepsis. Okay. Just, I think having that understanding helps you guys, like, know what's coming down the line, okay? If you have an understanding of that vasodilation, that leakiness, and that clotting, okay? Sepsis can also cause something called DIC, all right? You guys haven't learned about that yet, all right? But just realize that it can cause this, like, really, like, systemic issue with clotting so that it eats up all these clotting factors. What risk factors did Red have for sepsis?
Old age.
Diabetes, good. Age, somebody said age. Poor nutrition.
Open wound.
Open wound, very good. Very good. So how do patients with sepsis normally present? What are they looking like? Pain, increased pain, very good. Diaphoretic, good. Say that, I can hear that one. Confused or disoriented, like a change in mental status. Okay. What about their heart rate and respiratory rate? Can be increased. What about their blood pressure? Good. We talked about some diagnostic tools. I realized that, like, for this particular one, for your objectives as like a whole, you guys don't have a lot of blood tests besides the CBC with the differential, the urine cultures, the sputum cultures. So just have an idea of, like, you know, that bundles are going to be presented to you in the hospital or a sepsis protocol, and they're going to include a lot of these different things. Okay, the ABGs, the CBCs, the lactate levels, all that kind of stuff, okay? Electrolytes. All right, so for a patient with sepsis, what's the number one first line treatment? Fluids, okay? We need to replace the volume. A lot of times they'll look at that blood pressure and see if it's less than 90. They also look at something called the mean arterial pressure, the MAP, okay? What happens at, or what's a priority after the fluids? Cultures, and then what? Antibiotics, good. And what about the O2? I think that's important on the priority list, right? We're going to help them kind of compensate, right? Decrease in blood pressure. We're going to make sure that they're oxygenating well. How do we know that somebody with sepsis is getting worse? If they're decompensating. Okay. So decreased perfusion, right? So decreased perfusion means could be everywhere. So we're looking at things like urine output. your thready pulses, right? He had +1 pulses.
Mental status gets worse.
Mental status may change. That prolonged capillary refill, his was at 4.
Increasing temperature.
Might have increasing or possibly decreasing temperature, right? Okay, guys.
You gonna post the PowerPoint?
No.
Okay.
Sorry. No. Any questions before you guys are done? Yeah?
Did you say that they're not clotting?
So, with, you guys don't need to know anything about DIC. DIC is something that you guys will learn about later. But just realize that these people